All right, let's dive into a topic that every single medical trainee is going to face, guaranteed: how to handle a head injury in those critical first moments. We're going to build a really clear, step by step framework so you can walk into these situations feeling confident and ready to go.
So picture this. The trauma bay doors fly open. You've got a patient with a head injury, and all eyes are on you. The pressure is on. What is your absolute first move? That's the question we're going to answer today. Okay, so before we can do anything, we all have to be speaking the same language. A traumatic brain injury, or TBI, is just damage to the brain from some kind of external force. Now, this can be anything from something temporary and functional, like a concussion, to something permanent and structural, like a bleed in the brain. So your first job, right out of the gate, is to figure out just how serious this injury is.
And that brings us right to step one: assess the severity. And look, this isn't about making a wild guess. There's a standardized tool that needs to be your go-to every single time.
That tool is the Glasgow Coma Scale. You'll hear everyone call it the GCS. You can think of it as the universal language for describing a patient's level of consciousness after a TBI. It's objective, it's super fast, and it lets you communicate a really complex clinical picture to any other doctor, nurse, or provider with just a single number. It's incredibly powerful.
Now, don't get overwhelmed by the chart. The GCS breaks consciousness down into three really simple things: eye-opening, their best verbal response, and their best motor response. You just assess the patient's best response in each of those categories, add up the scores, and you get a number somewhere between 3 and 15. The most important thing to remember is this: a lower score always means a more severe injury. So once you have that score, you can immediately classify the TBI. A score of 13 to 15, that's a mild TBI, what most people would call a concussion. A score of 9 to 12 is moderate, and anything 8 or below, that's a severe TBI. This classification is the critical fork in the road. It's what's going to guide every single decision you make next. All right, let's move on to step 2, investigate and diagnose. So we know how severe the injury is. Now the huge question becomes, do we actually need to look inside their head with a CT scan?
You are going to face this question constantly. I mean it. The vast majority of head injuries that come through the door are mild, so knowing who absolutely needs a CT scan versus who can be safely watched is a crucial skill. And thankfully, we've got some very clear guidelines to help us make that call.
Just think of this as your safety checklist. If your patient with a mild TBI has any one of these things, they get a head CT, no questions asked. You'll notice age over 60 is on there. You might wonder why. Well, as we get older, our brains shrink just a little bit, and that stretches the veins that connect the brain to the skull, making them way more likely to tear. The whole point here is to play it safe and make sure we don't miss anything serious.
So when you do get that CT scan back, what are the big, scary things you absolutely can't miss? The two main ones are epidural and subdural hematomas. The key difference, the thing you have to know, is where the blood is coming from. An epidural is an arterial bleed, usually from a skull fracture that tears an artery. A subdural is a venous bleed from tearing those bridging veins we were just talking about.
And you can see that difference so clearly on the CT. Look here on the left, that's the epidural hematoma. See how it looks like a lens? That's because the high-pressure arterial blood is literally pushing the brain away. Now look at the right. The subdural hematoma is shaped like a crescent because that lower-pressure venous blood just spreads out along the curve of the brain. Recognizing these two patterns is a make-or-break clinical.
But hey, remember, it is not all about the fancy scanner. Your physical exam is so important. If you see this bruising right behind the ear, that's called battle sign. This is a huge red flag for a basilar skull fracture, which is a very, very serious injury. Your eyes are one of your best diagnostic tools.
Okay, let's move on to step 3, management. We've figured out how bad it is, we've looked for the cause. Now, what do we actually do for our patient?
For a mild TBI or concussion, our management is mostly about reassurance and good education. The old advice of locking someone in a dark room to rest, that's totally out. We now recommend just 1 or 2 days of relative rest, and then a gradual return to activity as they can tolerate it. For headaches, you want to stick with simple stuff like acetaminophen or NSAIDs, and please avoid opioids. If their symptoms are still hanging around after 2 weeks, that's your cue to get them to a specialist.
Now, for a severe TBI, it's a completely different world. This is critical care, and our entire goal is to prevent secondary brain injury. See, the first injury, the impact, has already happened. We can't change that. Our job is to stop the domino effect of more damage. That means we become obsessed with preventing low blood pressure and low oxygen. Every single drop in either of those can wreck an injured brain. We also actively manage brain swelling, prevent clots, and go after fevers aggressively. Every one of these steps is about saving brain cells. And here is a critical, absolutely critical point you have to burn into your memory. People used to think that steroids might help with brain swelling. We now know for sure they do not. In fact, glucocorticoids actually make the outcome worse in severe TBI and increase the risk of death. The rule is simple, it's absolute, avoid them, period.
Let's wrap things up with a quick look at step 4, recognizing special cases. The principles we've talked about apply to pretty much everyone, but there are a few groups of people where we need to think a little differently.
For any athlete with a suspected concussion, the rule is totally non-negotiable. When in doubt, sit them out. They have to come out of the game immediately and be properly assessed. And they can only go back to playing after they are 100% symptom-free, not just while sitting around, but after we've challenged them with physical exertion, too. You know, TBI is often called the signature injury of modern warfare, and it has this huge overlap with mental health. It's so important to screen any service member with a TBI for things like PTSD and depression. Their care absolutely requires a whole team of people to address both the physical injury and the psychological trauma that can come with it. And finally, 2 more high-risk groups to always have on your radar. Older adults, especially folks over 75, are at a much higher risk of being hospitalized and even dying from a TBI, often after a fall that seems pretty minor. And any patient on a blood thinner who hits their head is a neurological emergency. They are at massive risk for a catastrophic bleed, and reversing that anticoagulation needs to be a top priority. I want to leave you with this one clinical pearl because it really drives home just how high the stakes are with these patients. Someone with a deadly epidural bleed can walk into the ER, talk to you, and seem totally fine. This is the infamous lucid interval. And then, suddenly, they can decline catastrophically. Your vigilance, your close watch, that is their lifeline.
So that's our framework for the acute management of a head injury. But you know what? The care doesn't stop when that patient leaves the emergency department. So our final question for you to think about is this. After you've stabilized your patient, what are the subtle, long-term things like headaches, being irritable, trouble sleeping that you're going to watch out for in the weeks and months ahead? Because that follow-up, that's what makes for truly great patient care. Thanks so much for joining us.